This conference will now be recorded.
All right, the live stream has started. You're welcome to go ahead and start the medical board meeting.
Thank you, Tessie. Hear me okay? So the time is 10:19 a.m. The July 8th, 2020 meeting of the State Medical Board will come to order with the following members present via video conference. Dr. Rothermel?
Present.
Dr. Safran?
Present.
Mr. Jackalone?
Here.
Dr. Sohn?
Present.
Dr. Johnson?
Present.
Dr. Coccarella?
Present.
Mr. Ganadakis?
Present.
Ms. Montgomery? Hi, Ms. Montgomery. Dr. Feibel?
Here.
Dr. Bechtel?
Present.
And myself, Michael Schottenstein, here. Do I hear a motion to approve the minutes of the June 10th, 2020 board meeting?
Dr. Bechtel, so moved. Second.
All in favor?
Aye.
Aye.
Thank you. We'll turn to the reports and recommendations, please. The board will now consider the reports and recommendations appearing on today's agenda. Has each member of the board received, read, and considered the hearing record, the findings of fact, conclusions, and proposed orders, and any objections filed in the matters of Stephen N. Crow, MD, and Kenneth Hanover, MD? Roll call, please. Dr. Rothermel?
Yes.
Dr. Safran?
Yes.
Mr. Jackalone?
Yes.
Dr. Sohn?
Yes.
Dr. Johnson?
Yes.
Dr. Coccarella?
Yes.
Mr. Ganadakis?
Yes.
Ms. Montgomery?
Yes.
Dr. Feibel?
Yes.
Dr. Bechtel?
Yes.
And myself, Michael Schottenstein, yes. Further, does each member of the board understand that the board's disciplinary guidelines do not limit any sanction to be imposed, and that the range of sanctions available in each matter runs from dismissal to permanent revocation or permanent denial? Roll call, please. Dr. Rothermel?
Yes.
Dr. Safran? Dr. Safran? Okay. Mr. Jackalone?
Yes.
Dr.
Yeah.
Dr. Johnson?
Yes.
Dr. Coccarella?
Yes.
Ms. Montgomery?
Yes.
Dr. Feibel?
Yes.
Dr. Bechtel?
Yes.
And myself, Michael Schottenstein, yes. Does each member of the board understand that in each matter eligible for a fine, the board's fining guidelines allow for imposition of the range of civil penalties from no fine to the statutory maximum amount of $20,000? Roll call, please. Dr. Rothermel? Dr. Rothermel? It's a yes.
Yes.
Dr. Safran?
Yes.
Mr. Jackalone?
Yes.
Dr. Sohn?
Yeah.
Dr. Johnson?
Yes.
Dr. Coccarella?
Yes.
Mr. Ganadakis?
Yes.
Ms. Montgomery?
Yes.
Dr. Dr. Feibel?
Yes.
Dr. Bechtel?
Yes.
And myself, Michael Schottenstein, yes. In accordance with the provision in Ohio Revised Code 4731.22F2, specifying that no member of the board who supervises the investigation of a case shall participate in further adjudication of the case, the secretary and supervising member must abstain from further participation in the adjudication of any disciplinary matters. In the disciplinary matters before the board today, Dr. Rothermel served as secretary and Dr. Safran served as supervising member. During these proceedings, no oral motions may be made by either party. Finally, respondents and their attorneys addressing the board will be allotted 5 minutes to do so. The board parliamentarian will advise when the 5 minutes has expired. The assistant attorneys general will be subject to the same limitations. Please turn to the matter of Stephen N. Crow, MD. Ms. Lee was the hearing examiner. Objections to the report and recommendation and a request to address have been made on Dr. Crow's behalf. However, the objections and requests to address were not filed within the board's established deadlines for today's meeting. Therefore, the board will vote on this matter. Do I hear a motion to accept the objections filed by Dr. Crow for the board's consideration and to grant his request to address the board? Is there a motion?
Dr. Coccarella, so moved.
Thank you, Dr. Coccarella. Is there a second?
Second.
Dr. Bechtel, thank you. Roll call, please. Dr. Rothermel?
Abstain.
Dr. Safran,
Abstain.
Mr. Giacalone,
Yes.
Dr. Soin,
Yeah.
Dr. Johnson,
Yes.
Dr. Cacarella,
Yes.
Mr. Gonidakis,
Yes.
Ms. Montgomery,
Yes.
Dr. Feibel,
Yes.
Dr. Bechtel,
Yes.
and myself, Michael Schottenstein, yes. The motion is approved. The objections will be accepted into the record for the board's consideration. Dr. Crow or his counsel may now address the board. 5 minutes will be allowed for that address.
Thank you very much. First of all, I just want to apologize for the trouble that I caused, and this has been very trying. I read through the recommendations and I willingly accept those. I just wanted to bring to you guys' attention, with the virus and being a very small practice, I've literally been without an income for 3 months, and I understand how the monetary penalty was determined, but I just wanted to ask for any leniency that you can provide for that. It's going to be very tough. So that's all I have to say. I apologize again. I understand what I did, and thank you.
Thank you, Dr. Crow. Does the Assistant Attorney General wish to respond?
Good morning. I would like to thank the board and the hearing examiner for getting this matter to you so quickly. This was a recently cited case, and we set it for a hearing very quickly, and the hearing examiner turned the report on very quickly given the circumstances. For this case, I just want to say I think it is important that the board had the opportunity to listen to this case. This was an immediate suspension case based on an intervention move conviction out of Northeast Ohio. And I think that reading through the facts of the underlying case and the hearing examiner, I think that you can understand why it was important to get this to the board very quickly, and it gives you perspective. I don't believe that we've had an intervention move conviction based on something other than a substance abuse issue. So I think it was important for the board to recognize that courts can do intervention move conviction for various reasons. But I think that the hearing examiner has done a very good job of putting everything into writing, sending the facts and circumstances of the case, and I would ask that the board please accept the report and recommendation from the hearing examiner. Thank you.
Thank you so much. Is there a motion to approve and confirm the proposed findings of fact, conclusions, and order in the matter of Dr. Crow?
So
Motion,
moved.
Dr. Johnson. Is there a second? Dr. Sohan, thank you so much. I will now entertain discussion concerning the matter of Dr. Crow. Is there any discussion?
Michael?
Yes, sir. Mr. Giacalone.
I actually would propose an amendment to the order and move to no further actions. And I would the reasons are as follows. I look at this case, and honestly, I sit in awe. It's as if common sense and equity in terms of justice went out the window. We have a physician who, once he finds out his billing assistant is writing prescriptions in his name without his organization, calls the police and the board of pharmacy. The billing assistant is convicted of writing at least 60 illegal prescriptions, but then she, the convicted criminal, brokers a deal with the prosecutor to testify against the respondent because he wrote one prescription for Retin-A and acne cream, not a controlled substance, not a drug of abuse, but an acne cream for his own use. However, it makes a mistake by putting the RX in the billing assistant's name, not his, because she's going to the pharmacy and she can pick it up for him. Respondent testifies he didn't know this was wrong, but owns up to this. Now he's facing felony charges for this, but plea bargains to a lesser charge, which is still a felony of the 5th degree, where he can be sentenced to prison anywhere from 6 to 12 months. Again, keeping in mind this is for writing for one prescription for an acne cream. The court gives him treatment in lieu of conviction, where he undergoes at least 1 year of community control, is required to follow assessment recommendations, including continued mental health treatment, and to undergo random drug testing. So he's having this imposed upon him, even though he has no abuse or addiction issues. He just wrote an improper RX for acne cream for his own use, but placed it in the name of another person. Again, he told the truth here, even though he could have lied about the acne cream. At the board hearing, respondent's attorney says the following, which pretty much sums it up. Quote, and I'll share something with you that is not of the record, but it's the truth of the matter, in that the prosecutor said to me, you know, had he said, no, I never did that, this whole thing would have went away. But he was honest. And then the pharmacy representative said, well, that's a violation, and here we are. And now respondent comes before us for further discipline. Honestly, I think the respondent has suffered more than enough for his mistake. I see no need to add any further punishment or to pile on to that which is already suffered at the hands of our legal system. Again, I'm still in law to understand how the punishment he was given by the court fits the crime, given that his original goal was to stop a serious crime being committed by his billing assistant, and he admitted to committing a violation involving a prescription for an acne cream, a violation that hurt no one. I doubt he'll ever do anything like this again, and I believe that perhaps our decision of no further action might restore his faith in a system which I personally believe imposed an unnecessarily harsh penalty upon him. That's all I have.
Thank you so much,
Mr. Chairman,
Okay, Ms. Montgomery, yes, hi.
I can't tell you how much I agree with Mr. Jackalone. This is just a hammer that came down on a small nail. I think the prosecutors were thinking that perhaps we had something else going on. After all, you've got an assistant that wrote 60 scripts, and perhaps something happened with the doctor. But I just think this is just a miscarriage of justice, and I would underscore the fact Mr. Jackalone's amendment and would second it.
Thank you, Ms. Montgomery, for the second. Is there further discussion, Dr. Feibel?
I agree wholeheartedly. This is crazy, and a message should be sent that we as the medical board at least think what the courts did in this case is wrong, unfair, and unjust. And this is the best we can do to make that clear.
Thank you, Dr. Feibel. Mr. Ganadakis.
If I may, and maybe there's no one that wants to opine on this, but how did we get here? And I agree with Mr. Giacalone and Betty and Jonathan, but why is this? I mean, why are we here? Why is this before us? Why didn't we take care of this month ago, 6 weeks ago, or whatever it is? I mean, should this be before us?
Good question.
I have one more comment about that. You know, I have one more comment about that. And I'm thankful that they got this to us quickly and expeditiously. But I believe that the investigators' time in our office could be spent better. And in the future, I don't know who's prioritizing these cases, but I would ask respectfully that that be looked at.
Thank you, Dr. Feibel. Dr. Bechtel.
I just want to comment on, I agree with the comments that have been made. And just a comment on tretinoin cream. Being a dermatologist, we use that a lot. There are other retinoids that are currently over the counter. Tretinoin can be obtained in other countries without a prescription. It's not habit forming. It's not a scheduled drug. It's simply an acne cream that could potentially be eventually sold over the counter. So I think a fine of $18,000 is very, very excessive, considering the fact that this is a very simple medication that's not scheduled or addictive.
Thank you, Dr. Bechtel.
Mr. Chairman.
Yes, Ms. Montgomery.
Just one question. And I know that the supervising member, as well as the secretary, can't respond to this, but I see this, unless I've read this wrong, this came to us by a summary suspension. And I don't know how that happened. When we've seen so many other cases, well, I can't say so many, but we've seen cases where we're saying, why aren't we doing a summary suspension? But we have unless at the time it was presented that perhaps we've got a deeper problem here. But I'm not sure, unless I missed something, this man was summary suspended because of the felony.
So I think,
I assume
Ms. if I'm not mistaken, this was a pharmacy board suspension, right? This wasn't our suspension.
It was an immediate suspension based on the felony related to drugs, the illegal processing of drug documents. So that's a statutory immediate suspension.
Was that ours or was that pharmacy board?
It applies to the medical board, but it's not in our section.
Okay.
So I don't think I'm clear. Our notice says summary suspension. Was it summary suspension? We did a summary suspension, also, right?
I believe it was an immediate suspension.
Which is different than
like summary suspension, but the statutory authority is different.
Okay, the result is the same. So we took his livelihood away on a treatment in lieu. At the time that he entered a plea, and I think he was sentenced almost immediately. Somebody has that timeline. So he was in a treatment in lieu, and we took his livelihood away on one issue, and he didn't even get, when he finishes his treatment in lieu, he's even convicted. So I'm just amazed that I couldn't agree more with Michael, going to dock us, that perhaps if there is any way to not have this come to us, we should have tried to resolve it immediately and allow him to begin to practice if we had a vehicle to do that. So,
can I ask a clarifying question? With the immediate suspension, if there's a felony conviction, do we automatically have to do an immediate suspension? Is that a requirement?
I think you may. I need to look at the statute.
They haven't done it in the past. There's been lots of people who have come through, I think, that have been convicted of crimes that have come through on a normal site because we've been told that they aren't practicing currently because they're in jail or whatever, that we do not do a summary suspension on. I mean, that's been one of my pet peeves along the way is we need to do summary suspensions on certain people, and then we do it on somebody who's prescribed Red and A illegally. I mean, it's crazy.
Yeah, and again, this is the distinction, though, right, between immediate suspension and summary, right? Summary is we go on our own. Immediate is statutory requirement triggered by the felony. My question is, on the felony, do we have, is that a shall or is that a may? That's the thing. Mindy's not right in your head. Do we know that for a fact it's a shall?
I believe it is, but like I said, I'm looking for the statute.
That's a
big... And one of the other things, Bob, is Mr. Giacalone, is that a conviction, you're considered convicted at the time that you are sentenced, and under the treatment in lieu statute, that's another thing. I don't know if it's conviction because by definition, it's something that says you won't be convicted if you do X, Y, and Z. So. Again, that's another sort of twist in this that just raises the question, how did we get here?
Thank you, Ms.
Meanwhile,
oh, sorry.
Good. Never mind.
Dr. Sohn, you have your hand up?
Yes, thank you very much. First of all, I want to start by saying that I agree with no further action on Dr. Crow, but I do want to point out a couple of things that I don't particularly like in this case, and I hope that Dr. Crow or other physicians can learn from some of these situations. Because, I mean, I know we're being very nice to him and all that, but he did some things that I don't consider to be well done. First of all, there's 60 charges here of felony prescriptions. And I understand that we're victimizing Dr. Crow, but at the same time, he should have been more vigilant in maintaining his prescription pads. For example, he should have had an inventory of his prescription pads because those are so valuable and can be used. He should know where his prescription pads are at all times. And honestly, I don't even think he should be using prescription pads in the day of electronic medical records and two-factor identification to prevent prescription drug fraud like this. he should really consider using some of those technologies. So I don't think that it was really good. And I understand he's a victim that someone stole from him, but he should have had control mechanisms to prevent that theft in the first place. Secondly, I think writing a prescription deliberately under someone else's name is a bad idea, even though it was a non-controlled substance. And I think that was poor. I think he should have known that that was not right. He may decide to plead ignorance and say, well, I didn't know I should have done that, or I didn't know that was wrong. But honestly, come on, you really should know that. Those two things are not very good behavior by a physician. On that note, I want to make that noted here, and I want to make that noted that we recognize that behavior is not appropriate. At the same token, I do believe he has suffered severe consequences that has affected his life and livelihood. I don't believe we're going to see him back, and I don't believe he represents a harm to the public at this point in time, given everything that he's had done. So I do support no further action.
Dr. Schottenstein, can I just provide a little bit of information about the statute about immediate suspension?
Please.
Okay, so it's 3719-121C, and the board, so it applies to other licensing boards, not just the medical board. And when the board receives notification that a licensee has been convicted of a crime under 292942 or 371912, so a drug offense, then the board shall immediately suspend the license and shall notify the holder. So you do that through approval on sites, but 3719-121 does state that it shall be immediately suspended on notification of the conviction.
So the only thing you have to check.
It talks about a guilty plea, intervention in lieu, or finding by a jury or court. And that's 3719-121C.
What is the treatment in lieu? Is that considered a conviction? And
so it states, on receiving notification, the board under which a person has been issued a license shall suspend the license of that person on a plea of guilty to a finding by a jury or court of the person's guilt or conviction of a felony drug abuse offense, a finding by a court of the person's eligibility for intervention in lieu of conviction, a plea of guilty to, or a finding by a jury or court. And so it's tied to felony drug offenses.
Well, that answered the question. Thank you.
Thank you.
Further discussion? I certainly support the no further action, and I thank everybody for their thoughtful comments. Let's have a roll call vote, please, on the amendment. Do I hear a motion to approve and confirm the proposed findings of fact as amended in the matter of Dr. Crow? Motion?
So moved.
Dr. Bechtel?
Second, Dr. Cockrell.
Thank you. I got it.
Is this on the amendment?
This is on the amendment. Before voting on the motion to approve and confirm as amended, is there any further discussion? Okay, we'll have a roll call, please. Dr. Rothermel?
Abstain.
Dr. Safran?
Abstain.
Mr. Giacalone?
Yes.
Dr. Sohn?
Yes.
Dr. Johnson?
Yes.
Dr. Coccarella?
Yes.
Mr. Ganadakis?
Yes.
Ms. Montgomery?
Yes.
Dr. Feibel?
Yes.
Dr. Bechtel?
Yes.
And myself, Michael Schottenstein, yes. Thank you, everybody. Please turn to the matter of Kenneth Hanover, MD. Objections have been filed and were previously distributed to board members. Mr. Porter was the hearing examiner. A request to address the board has been filed on behalf of the state. 5 minutes will be allowed for that address.
Do we want to tell Dr. Crow that what this means? Because he doesn't seem to understand what we've just done.
I understand it.
Did we vote on the amendment and then vote as amended? Because I think there was only one vote.
We missed it. Yeah, we need to vote.
Oh, okay. So
we probably need to vote twice because technically we just voted on an amended. I mean, I'm not parliamentarian, but we voted on the amended findings before we voted on the amendment.
yes, so we did. We'll just go backward then and have a roll call vote on the amendment, please. This is in favor of the no further action amendment. Dr. Rothermel,
Abstain.
Dr. Safran,
Abstain.
Jackalone,
Yes.
Dr. Sohn,
Yes.
Dr. Johnson,
Yes.
Dr. Coccarella,
Yes.
Mr. Gandadakis.
I'm going to second Robert's I'm not sure if someone seconded for purposes of discussion. So just for the record, I'll second his original amendment and vote yes as well.
Thank you so much. Ms. Montgomery,
Actually, I think
Yeah.
Ms. Montgomery had seconded.
I seconded it, but yes.
Dr. Feibel,
Yes.
Dr. Bechtel,
Yes.
and myself, Michael Schottenstein, yes. So are we in good shape now for Dr. Crow? Okay, we'll move on then to Dr. Hanover and have a statement from the state, if you're so inclined.
Good morning. Can you hear me, everybody?
Morning, hi.
Right. Hi. Thanks for the opportunity to address you this morning. I know that it's rare that the state asks to go first, but I felt like this was a pretty exceptional case. What you have before you this morning is a drug-addicted anesthesiologist with a proven pattern of stealing drugs from the operating room to feed his addiction. And now the board has very credible eyewitness who saw him do it again. You know, as a consumer, as a patient, I personally can't imagine many things more terrifying than my anesthesiologist huffing drugs and falling asleep while my life is literally in his hands. But that's exactly what Katie Grace, the x-ray technician in the operating room with Dr. Hanover, saw him do on February 12th. So as the lawyer for the state, I argue that you now have an eyewitness who has consistently and credibly said that she saw Dr. Hanover put a piece of gauze underneath a leaking sevoflurane machine, an anesthesia machine, put it to his mask and inhale deeply multiple times until he passed out. And then she did exactly what she was supposed to do. She reported that up the chain. And Katie Grace was standing 6 feet away from Dr. Hanover. She never saw him put a packet of alcohol wipes, you know, open that packet, put a piece in gauze and put it up to his face like he claims. You know, I agree with the hearing examiner. This case really comes down to one of credibility. There is no commercially available test for sevoflurane in one system. So you as a board have to decide, do you believe Katie Grace or do you believe Dr. Hanover? Because it can't be both. The stories are not consistent. And as you make that decision, I want you to keep in mind that Katie Grace had no axe to grind with Dr. Hanover. In fact, she hadn't even met him before. She didn't know he had a drug problem before working with him that day. And I think that's very powerful. Why would she lie about this? She, in fact, had every reason not to say anything. She had every reason to just look the other direction, because as an x-ray technician, making an allegation like that against a physician, accusing a physician of wrongdoing in his work, she really had a lot to risk. And I frankly appreciate Katie Grace's courage to do the right thing in this case. So as a consumer, I'm telling you, this is terrifying, that allowing an anesthesiologist to continue to practice anesthesia after knowing what the board knows will rock the public's faith in this profession. And as a lawyer for the state, I argue that Dr. Hanover's past criminal charges for stealing drugs from the OR, combined with Katie Grace's eyewitness account that he did it again on February 12th, is enough to find he relapsed. I've read Dr. Hanover's objections, and I agree. He either used the sevoflurane during the surgery or he didn't. This board has to decide that based on the record. You've read the transcript, you've read the exhibits, you have everything before you that you need to make that determination, but you have to make that determination because it's not enough to find that he had a monumental lapse in judgment. That's really troubling, but shocking even, but that's not evidence that he relapsed. I also want to say what makes Dr. Hanover's relapse truly dangerous is that he does not understand his addiction. He is in total denial. He claimed during the hearing that he made a rational decision to risk his entire career to steal drugs from the OR at his former employer to treat his back pain, rather than just to take an hour off of work to go see a pain medicine specialist. Think about that statement. You know, who would rationally decide to commit multiple felonies to jeopardize one's entire profession in order to avoid going to the doctor? You know, that to me is just a window into his thought process. It shows that he's still impaired and he doesn't understand his impairment. He has not learned from his past treatment. The board cannot allow Dr. Hanover to practice anesthesiology again. You cannot risk it. The state therefore asks that you take him out of practice. You either adopt the report and recommendation, or you put him back into a step 1 consent agreement with a suspension and permanently limit him from practicing anesthesia, because he has now shown he cannot be trusted to be around those medications with his history. Therefore, the state respectfully requests that you take appropriate action on his license to protect the consumers in the state of Ohio. Thank you.
Thank you so much. Does Dr. Hanover or his attorney wish to respond?
Yes, we would, please. Good morning, everyone. My name is Greg Toposi with the law firm Dinsmore and Scholl. Obviously, we represent Dr. Hanover in this matter. I'm actually going to reserve my remarks to the end of our 5-minute allotment and turn the floor over to Dr. Hanover to address the board at this point.
Good morning. I'd like to thank the board for this opportunity to address me. The facts of what had transpired during the time prior to my having first come to the board's attention, it was 20th, 2018, are fully detailed in my consent agreements, so I will not readdress them here. However, I would like to point out that as it relates to the most egregious error that I have ever made in either my professional or my personal life, I have assumed and continue to assume full responsibility for the actions that I have taken and still deal with both the shame and remorse that have stemmed from them. Regarding my subsequent period of sobriety following inpatient treatment, I have continued therapy through weekly aftercare meetings as well as caduceus and AA meeting attendance, working the program with the sponsor in addition to complying with all of the other terms of my consent agreement. I have taken the time to reflect upon the character defect of self-importance that initially led to me justifying my self-medicating for my chronic hip and back pain, culminating in the need to confront my resulting addiction. Through my work in the program, I have gained invaluable insight to understanding the disease of addiction and have just as importantly been incredibly humbled by the fact that I was capable of becoming and indeed had become an addict. The lack of trust and the jeopardy that I placed my family in as a result of my addiction was at times an overwhelming burden to bear. Achieving and maintaining sobriety through working the program has allowed me the chance to slowly repair some of that damage. Ultimately, after what was a long year of seeking employment, during which I was fully candid about my addiction, I was finally able to secure a position at Madison Health. I was incredibly grateful for this opportunity to again feel useful in the career that I have devoted my life to. But again, what mattered most to me was the healing that was taking place within my family, my marriage, and myself. On the morning of February 12th, while having been ill for the preceding days, my only thought was to not have my patient's surgery delayed, nor let down the people who had given me the second chance by my calling in sick. I realized that in retrospect, not prioritizing my own well-being jeopardized that of the patient. This was a mistake that, if given the chance, I will never repeat. However, as to the question of whether or not I relapsed in an OR full of people by using a medication such as sevoflurane, which clearly would have put me to sleep for a significant period of time, I can honestly and emphatically state that I did not. Upon realizing how my nodding off for a minute or two may have been interpreted, I immediately decided to voluntarily submit a urine sample for screening that day, as I had been advised to do by fellow caduceus members should a question ever arise. I consider my sobriety paramount to anything else in my life. 2 days later, I freely admitted to the investigators that I had taken 2 Mucinex D over a period of 2 days to alleviate the congestion I had so that I could again make use of my CPAP. I have since become aware that my taking Mucinex D was a violation of my consent agreement that I have learned from and will not repeat without first consulting with my primary care provider. During the nearly 5 months since that date, while not being employed and enduring the stress that this event has caused, I have redoubled my commitment to working the program, and I can honestly say that my sobriety continues to remain the primary goal in my day-to-day life. I will reiterate that I have never inhaled sevoflurane, be it in February of 2020 or at any other time. I have not nor will I jeopardize what I have reclaimed in my life, and to that end, my sobriety date remains August 20th, 2018. Thank you for both your time and consideration.
And briefly, I would note, this really is, as we noted in our objections, this is a common sense case, is that we have a physician without any sort of red flags that this board sees regarding relapse, as far as not, appearing for quarterly meetings or having problems at home or having problems with the job, anything like that. No red flags, a physician who is simply under the weather. And we know that not only from his testimony, but from testimony of the written words from his AA sponsor, as well as from the state's own witness, Nurse Shingler. And what did Dr. Hanover do? Is that he went to work. We've all done that. We tried to work through being sick, and he shouldn't have done that, just like he shouldn't have taken Mucinex D or tried to utilize alcohol to reduce his nausea. But what he did was try to treat himself just as far as a simple flu or simple sickness there. So in this instance, what the appropriate resolution is in this case is to reinstate Dr. Hanover's license pursuant to his step 2, his step 2, and continue along with him probation. He's been suspended for 4 months with what is a technical violation of his consent agreement, and he is ready to go into practice and abide by the terms of his consent agreement, which he's continued to do throughout his time with the board. So with that, we thank the board for its thoughtful consideration in this matter.
Thank you so much. Is there a motion to approve and confirm the proposed findings of fact, conclusions, and order in the matter of Dr. Hanover? Motion?
So moved, Dr. Johnson.
Thank you. Thank you so much. I will now entertain discussion concerning the matter of Dr. Hanover. Is there any discussion? Well, I guess I have some discussion. So there is, of course, this proposed order to permanently revoke the license in this case. And I feel like if we feel like there's a preponderance of evidence that shows that the doctor is guilty of what has been alleged, then I think that's the right order, because that behavior would in fact be egregious. And so defense counsel through the case made a lot of arguments in the doctor's favor, including the fact that he had been ill, and that was corroborated. We know about the toxicology screen, and there were statements to the effect that he woke up quickly after passing out, that slurred speech and dilated pupils were not noted, that he ended up completing the procedure after a 15 or 20-minute break, and that the addictionologist that he consulted thought the allegation of sevoflurane abuse during the procedure was highly unlikely, and that the other anesthesiologist, Dr. Chu, picked the gauze out of the trash and smelled it, but apparently wrote a letter in support of the doctor. I say apparently because a lot of it was redacted. So what I would say is that all of those points raised by defense counsel are compelling, but they don't disprove the allegation, they just cast doubt on it. And in contrast, we have this eyewitness testimony of an X-ray technician who testified, as we heard, that at close proximity, she saw liquid dripping from the underside of the vaporizer onto a piece of gauze on the table underneath. Then she saw the doctor take that same piece of gauze up to his mask 12 to 24 times. She indicated that he behaved in what looked like a furtive manner to her, as though he was trying to be stealthy in his behavior. And really, her testimony appears unimpeachable to me. She had a close-up, unobstructed view of this behavior. Liquid dripping from the machine onto the gauze. The doctor putting the gauze to his face, not once or twice, but 1 or 2 dozen times. The addictionologist opined that she misconstrued what she saw, but how do you misconstrue that? And, he did not say. So I made a real effort in my mind to give the doctor the benefit of the doubt and really took heed of the concerns raised by defense counsel. And I wanted to be careful that just because the doctor has a past history of abuse, even though that's compelling, that is not proof that he engaged in this behavior. So really what it comes down to for me is I believe the x-ray technician. I kept coming back to her testimony. I believe she saw what she saw. I believe she's being truthful about what she saw. I think she provided credible testimony that's sufficient to constitute a preponderance of the evidence that the doctor abused sevoflurane during the procedure in the operating room. So I agree with the proposed order. Is there further discussion?
Yes, I'd like to discuss further as well.
Hi, Dr.
Okay, thank you. As you guys know, I'm an anesthesiologist, and I make a couple of points here, particularly about anesthesia and the anesthesia machine regarding dripping of sevoflurane. And from a technical aspect, that canister has to be refilled with the actual liquid that becomes vaporized into a gas that you breathe in. And because there's a valve that you need to refill it, it is possible that it can leak. But sevoflurane has a very distinctive odor to it. And I think that if it was leaking significantly to the point where things happened that he claimed, I would think that other people would have recognized that within the operating room. But more importantly, before you do an anesthetic, you do a machine check. And that involves checking your ventilator, checking your machine, checking your canisters to make sure these things aren't happening. So even with that, it's very questionable or suspect that something like this would happen and not be recognized. In other words, it would be poor medical practice to even allow a leaking machine to happen in the first place if you believe it. But I would say with the past history that he has, it's very concerning. Anesthesiology is different than other fields, right? Because you are oftentimes alone with a patient that is critically asleep. And, these are very critical times. It's almost like taking care of an ICU patient when someone's asleep. And if that person's alone in there, I don't know if you want someone with this type of history and this types of things to be taking care of yourself or your family. And when we're talking about protecting the public, I would feel very uncomfortable to have anesthesia from this physician for myself or anyone that I know. I support the order of permanent revocation.
Thank you, Dr. Sloan. Is there further discussion?
Mr. Chairman?
Yes.
I have a comment, but may I ask Dr. Sloan a question before I have a comment? Is passing out, correct? I mean, what is it that if somebody were, I'm not a doctor, but if I were an addicted person, what do I get out of sniffing this particular drug?
Yeah, well, that's a great point. Not much. I mean, it doesn't give you a high like heroin or other drugs of abuse or ketamine or fentanyl, which I think he's used before. But I don't know if you've ever, it's basically a gas derivative of ether. I mean, some people enjoy inhaling pain thinner, gasoline or whatever it is. Now, at the point when you're initially inhaling the drug, right prior to you passing out, you do feel, some people could describe it as euphoria, but you do feel different. That might be a sensation that somebody who has an addictive personality may be seeking, given that they have access to other drugs. We have seen at least one sevoflurane abuse case here at the medical board before, where that particular person had a substance use disorder and was using sevoflurane. It's not a very common drug of abuse, though. To answer your question.
Thank you very much, Dr. Sloan. My comments, I find myself, it's very odd being a former prosecutor, being in position with the former case and this case. But I've tried lots of cases, and Ms. Snyder is such a good prosecutor. She is a very persuasive, not only in her presentation, but in her oral argument in closing here. I don't think that you can decide that the eyewitness misperceived as being lying. I think that what really for me defies and makes me come down on, yes, this man needs to be punished in some way. But what in looking at and this happens all the time with eyewitnesses, that what she sees 1, 2, and then makes a decision of that equals 5. Because she had showed great courage. She did exactly what we want our professionals to do. So I don't think that she was lying. I think what worries me is, and perhaps I'm just trying to add rationality to somebody who is addicted and not rational, is why would you do this when there are 10 people in the operating room? Why would you do this when the results of sniffing this drug may put you asleep, and or may not give you a high, may or may not, from what Dr. Soin says. Why would you do that? And so in looking at the evidence, I think the alarm is concerned, the alarm is appropriate. You've got somebody who made a decision. I'm somewhat alarmed that anybody thinks you can walk into an operating room with flu and think that that's okay. But again, I'm not a doctor. But that he made a decision that put his patient at risk, that requires some kind of punishment. I do not see convincing evidence, with all due respect to the state, who did a great job of presentation. I just don't see the evidence. I see Miss Grace as seeing him sniffing something on a 4x4 where he said he put his alcohol swab or whatever it was called. I don't know whether what she said she thought she saw was condensation. I don't know if you have condensation, or whether it's a dripping of that, because the question was never asked about whether that in the vaporizing process, does that cool the container to such a point that there is condensation. I just don't see it making sense. What I do see is, perhaps because we kept using the word pass out, fell asleep, is somebody who, having several days of not sleeping, and being ill, and being on his being in an operating room for as many hours as he is, I could see, and again, I'd say this with some trepidation in a room full of doctors, that this man may have either fallen asleep or passed out. But the fact that he was cognizant immediately upon having a tap on his shoulder, the fact that he did it in a room with 10 people, I mean, and that he didn't have any evidence of normal evidence that you would say dilated eyes, etc. The fact that you couldn't smell it, all of those things argue to say that we have people with good intentions, that Miss Grace being the hero here, and a doctor whose intentions were, once again, to think that he was, he's at a certain age, he's getting a second chance, he's new to the job, he knows that he's going to put everybody at risk if he leaves and requires somebody to come in, that his thought process is, whether you agree with it or not, is that I'm going to go in and tough it out, and he didn't make it. So for me, I think I have to say, with all due respect, I don't, and I would normally not say this, but I just am not convinced that this has been proven that this man was engaged in somehow, in front of everyone, abusing a drug. I am convinced he made bad judgment and he requires some kind of punishment, but I just don't think the circumstances warrant a permanent revocation. And I say that with all due respect to the state that did, I think, a very good job of presenting and has every reason to be worried, as we all are, about this the judgment of this doctor.
Thank you, Ms. Montgomery. Dr. Feibel has a comment.
Yeah. First, to comment about Ms. Montgomery's thoughtful comments. As somebody who's in the operating room and operating on a regular basis, there's often many people in the room. 10 is not an abnormal number, although sometimes less, sometimes more. But there's very little focus on the anesthesiologist in the room. Most people are not focusing on the anesthesiologist. So it would not be the anesthesiologist would not think that somebody is watching them all the time. So unlike the surgeon that would have a hard time getting away doing something like that because people are watching, that's where the focus of the surgery is. I don't think it's uncommon for an anesthesiologist to be able to do this, which is why anesthesiologists are traditionally people who are able to abuse certain of their drugs because no one is watching them for the most part. Secondly, what troubles me is he submitted to a urine sample right away. Of all medical professionals that would know that sevoflurane would not show up in a urine sample, an anesthesiologist would be the person that would know that best. So if he was trying to get some sort of feeling without having anything show up in his urine, there's very few drugs that would do that. So that might explain part of the reason he did the sevoflurane. And I just find his behavior at not his testimonial behavior, but the testimony about his behavior to be exceedingly odd. None of it makes sense. And what she says, the X-ray tech does make sense. And I just believe her more than I believe him. And I think it's explainable beyond what Ms. Montgomery has pointed out. Therefore, I will be supporting the permanent revocation.
Thank you, Dr. Feibel. Is there further discussion? Mr. Giacalone?
Yeah, this one's a difficult one, right? I mean, I don't think the X-ray technician is lying. I think she truly believes what she saw. Obviously, Dr. Hanover truly believes what he saw, or at least it's representing to us, he truly believes what he saw. But there's so many inconsistencies on this that it just gnaws at me. And maybe that's a credit to the defense counsel for building a nice case, or there's something wrong here. A couple of things. I think Dr. Soin had mentioned sevoflurane has a distinct smell. And Amol, please don't let me put words in your mouth. So you need to correct me if I'm wrong. And that it would be pretty noticeable. So how does no one notice that? And then Chu comes, his associate, takes a look-see, doesn't smell that? Wouldn't he smell that? That's the thing that puzzles me. On the other side, there's the alcohol story. Where are the foil packets? Nobody mentions those either. It's just a rodeo of inconsistencies. And for that, I'm kind of a little bit like Miss Montgomery. I think there's a good story. I'm not sure if it crosses the finish line, but on the other hand, I feel suspect that maybe it did. And here's kind of where I'm kind of landing on this, and it's a bit like splitting the baby in some respects. I'm not sure I can handle permanent revocation because I don't know if he crossed the line in my mind to conclusively do that, but I think he's got enough there that I'm willing to maybe accept that. So maybe is the middle ground here a suspension and a further probation spin out of where he's at now with additional monitoring or whatever, because I'm not sure, but it kind of looks like it. But on the other hand, I would hate to be wrong and give him the professional death sentence. So that's kind of where I'm kind of hinging on this one, is maybe a 90 to 100 day additional, 90 to a 180 day additional suspension, pull out his probation even longer, see if there's something we can find here about sevoflurane that we can incorporate in terms of testing. And I know that's a big question because it seems like everybody's saying that isn't an option. And if it isn't, well, so be it. I don't know what we do, or if there's some other lab out there that would be willing to do that. And again, Amol, you may have some thoughts on that. I don't know, but I'm just struggling with this case. Again, it's like putting somebody in a professional electric chair, and I'm not sure. I just question if there's enough to push him all the way there. I think there's enough to push him into the zone. I'm just not sure there's enough to push him there, at least from my perspective. That's my 2 cents.
Thank you, Mr.
Yeah, I can comment on the sevoflurane just because it's been brought up a lot. So the reason why sevoflurane is a great anesthetic is, you breathe it in, it gets absorbed through your lungs. And then when you breathe it out, you actually exhale it. And that's why he woke up so quickly. after being discontinued from the sevoflurane, it's not excreted renally, right? So it's actually excreted by breathing it out. So, I mean, the test would be very difficult. I keep coming back to the fact that as an anesthesiologist, you're alone in the operating room with a critical patient. It's not like you're a primary care physician, right? So, you know, we'd hate to see it, but if a primary care physician was impaired for 15 minutes or took a nap or something, I don't think anyone's going to die. If an anesthesiologist is, I mean, the patient's life could be at serious risk. Because of that, I still feel very uncomfortable. I mean, I think if when you guys are trying to decide this, ask yourself this question: would you want him to be the anesthesiologist in your son, daughter, mother, dad, or yourself? I mean, and if the answer is no, I think you have the answer on how you want to vote.
Thank you,
This is Dr. Tucker. Go ahead.
Dr. Tuckerello, go ahead, please.
Yeah, this is Dr. Tuckerello. I just wanted to echo what Dr. Soin said. An issue that can't be discounted here is the specialty that we're dealing with. Unfortunately, when you're in the operating room as a patient, you're completely dependent on the anesthesiologist to oxygenate you, ventilate you, monitor your hemodynamics, titrate drips up, down, add pressors for your blood pressure, and a whole host of other things, depending on how the case is going, how big the case is, and so on and so forth. And it takes only minutes with large hemodynamic changes to have somebody that's the patient could be, permanently disabled or even die if they're not at their fullest faculties. And that's the one thing that I think that is, I just keep coming back to, and to echo what Dr. Soin and Dr. Feibel have said. So I think that's to me, not the linchpin of the case, but certainly a huge factor in what decision we need to make here today.
Mr. Chairman, just to respond to Dr. Feibel, I think the fact that he sought a test immediately was because at that point, he may not know what it is he's being accused of. If he didn't sniff the drug, he may think because he passed out that he's going to be accused of having an alcohol problem or having taken some other drug. So that's why you go and get a test. That's why I would go get a test, is because if he did not sniff it, then he's got to know whatever he did, it was terrible to fall asleep if that's a fall asleep as opposed to a pass out. It's terrible to fall asleep in an OR room, in an OR. So he knows he's in trouble anyway. So to get a test is to show, look, I didn't fall asleep because I took some kind of drug. I fell asleep because I was sick. And
I don't know that I would agree with that, Ms. Montgomery. There are people that actually know that they have substance abuse problems to a drug that cannot be easily tested. We actually have had years ago someone that was not a physician but a healthcare worker, and they were actually taking synthetic opiates that you cannot detect on a tox screen that test for opiates. And they knew that, and they specifically wanted to get tested to, be discounted or be, vindicated that they were not a substance abuser.
So, Dr. Coccarello, you make my case, because on one side, you've got if I didn't do anything, and I can't imagine that somebody thought I was sniffing whatever this is, whatever the name of the drug is, which I don't pronounce correctly. But I know that I passed out. I know that they may think, given my history, I'm on some other drug. I know to get tested. And on the other hand, you have said exactly what you've said, which is, look, this is just a setup. I'm going to show you, this is pre-calculation. I'm just being smart, which puts us right in the bullseye. Did we prove this case? Do we know that, do we know whether there was condensation? Do we know whether there's any evidence that there were alcohol swabs being sniffed? Because that question wasn't asked. Did somebody look in the It might be you could ask the question and nobody looked, and so the answer is we don't know. But the answer is we don't know because we didn't ask the question, but we also don't know because apparently maybe nobody looked. So I guess my problem is I do think he's got a problem, that he should be punished. I just don't know that it reaches the professional death penalty that we're talking about, despite his background. And again, this goes against every other instinct and history I have, but I'm just, that's where I am. Sorry.
Thank you, Ms. Montgomery. Dr. Feigl?
Yeah, two things about that real quick. One is, I was going to say, and I meant to say before, that I've never heard of an anesthesiologist falling asleep in the OR while taking care of a patient. I don't care what the situation is. I mean, it just doesn't happen that I've seen. I've been in a lot of ORs. I would be shocked. So that violates the standard of care issue right away, which makes me nervous to begin with. And then you have this other evidence. The other thing is, she emphatically says that he took a piece of gauze up to his nose. The packets of alcohol swabs are not gauze. They're like they look like the end of what's inside of a Band-Aid almost. They're cotton, but they look nothing like gauze, and they're much smaller than a piece of gauze. And so you would never put the alcohol swab. I mean, I don't know why somebody would put the alcohol pad in a piece of gauze and bring it up to their nose if they're using it. They just bring the alcohol pad up to their nose. There just is so much inconsistency with what she saw and what he says happened that it doesn't make sense. I mean, again, if he had dipped the alcohol swab in the sevoflurane, the alcohol pad in the sevoflurane, she saw him dip the alcohol pad in there and bring it up to his nose, there could be a lot of controversy. But a piece of gauze looks very different than one of those alcohol pads that we use in the surgery. So I just think there are so many inconsistencies here that with his testimony and her testimony that you have to completely think that she's lying to find some other conclusion based on what he says.
Thank you, Dr. Feigl. Mr. Giacolone?
Yeah, I guess I don't see that way. And I don't think she's lying. I think she truly believes what she saw. The alcohol pads, you could put a number of those pads in a gauze and bring them up to your neck, up to your nose, because then you have additional alcohol that you're inhaling. So that's not out of the realm of reality. I mean, that's the problem with this case, right? Everyone you bring forward for one, you can take back for the other. You bring it forward for the testing. Oh, no, well, he did the testing because he knew how to game the system. Counter. No, he did the testing because he fell asleep and he knew he would be labeled on it. Counter again. He did it in front of a whole stage of people. His past history does not have him in front of a whole stage. He took it home and did it on the side. I mean, there's so many contradictions on this one. That's the puzzlement. For everyone that we throw up, it seems like you can throw another one back to rebut it. And that's where I'm struggling with this, quite honestly.
So the part that I could not rebut was the fact that, almost like links of a chain, the X-ray technician saw liquid drop from the bottom of the vaporizer onto a piece of gauze, then saw the doctor pick up that same piece of gauze and put it to his face dozens of times. So I don't know how I rebut that. I don't think that's condensation, because I don't know why somebody would put gauze with water up to one's face. And I don't know that the machine does that anyways. And so, you've got this liquid dripping from the bottom of the machine. The liquid hits the gauze. The gauze goes to the doctor's face dozens of times. How do we rebut that? I'm asking because I'm glad to know if we're able to. How did she misconstrue that? How did she not see what she thought she saw?
Dr. Schottenstein, I believe the evidence that, at least the testimony of Dr. Hanover, was that he placed the alcohol pieces, or whatever it's called, the alcohol swabs, in the gauze. So that is not inconsistent with what she saw. If the alcohol swabs were in the gauze and then he put it up to his face, any number of times, whatever he says one thing and she says another, but that's not really unusual in an eyewitness testimony at all, to have these sort of troubling little inconsistencies. But I just don't see that as inconsistent with what his testimony was. If you don't believe him, then Katie barred the door. But I don't know that it's necessarily inconsistent, and I certainly don't think she was lying. I think she was the hero in this story.
So again, I just want to understand it. She's saying liquid dropped from the bottom of the machine onto the gauze. He then picked up that gauze and put it to his face. Right? She's not saying anything about alcohol pads. She's saying liquid dropped from the machine to the gauze. The gauze then went to his face dozens of times. That's where I'm getting hung up. Further discussion. Mr. Jackson.
Yes, hi.
Oh, sorry, Dr. Swan, yes.
Oh, thank you. First of all, I really appreciate the two attorneys on the medical board's advocacy for this particular physician. You guys do a great job of defending him. And I just want to make sure that people are advocating for the public, as far as having this physician taking care of someone that you know and love. If this was a single isolated incident, like a one-time thing, I would agree with you. But when you're talking about ketamine, fentanyl, multiple years of issues and problems, a lack of awareness of what's going on, I definitely have some concerns. If the board really wants this gentleman to continue to practice medicine, I would like to say that I do support permanent revocation, but at a minimum, if you really want to go down this path, which I disagree with, the only thing I would stand for is a permanent restriction from ever providing anesthesia. And then perhaps you can retrain into a different field and significant rehabilitation to be let back in. Otherwise, I still don't support it. I just don't think it's safe. And I wouldn't trust any of my family or friends with a physician that has these issues.
Thank you, Dr. Swan. Mr. Jagalon.
I know we're going to beat this dead horse. Look, I don't think anybody here, including the attorneys, would advocate having someone come into practice who really thought he was out there. So, I mean, if we thought he was a problem, I would be the first one to propose permanent revocation. Again, the question becomes more of, did it make it? Did it cross the line? But, and then that's where I'm struggling. I mean, Michael, to your point about the dripping fluid, I guess my comment becomes, she's the only one that saw it. The nurse didn't see it. Nobody else seems to see this. She's the only one that sees this. Granted, I understand you got 10 people, everybody's running around doing other things, but she calls out the nurse on this one, and he doesn't see it. And then Chu comes in, this thing smells, he doesn't see it. I mean, just so many inconsistencies here. And I don't think the X-ray technician is lying. I truly believe she thinks she saw what she saw. The only question is, what did she see? And that's where I'm really struggling with it. So every time you throw one up, you can swat it down on the other side. I mean, it's kind of funny. Well, funny's not the right word. It's sadly amusing because we want a clear-cut case. We want to make the right decision. I just struggle with what is the right decision here. And I think, to Amol's point, I feel like, maybe some middle ground here is, because I think there's enough to get us to that side, but I'm not sure if it makes it enough for me to want to pull his license. And that's where I struggle with this. I don't think it's a clear-cut case, and I don't think he's a saint by any stretch. I just don't know how much of the dog he is, quite honestly.
Well, I think we've had a thorough discussion, and I guess I'm wondering if at this point you'd like to go ahead and have a vote.
Dr. Johnson wants to speak. I don't think she's spoken.
Sorry. Oh, hi, Dr. Johnson. Go ahead, please.
Hello. Dr. Feibel can probably attest to this as well. In the OR, we do open up alcohol packages. They're very small, like 2 by 2 centimeters, and we'll have patients inhale this to prevent nausea from coming on. This is very common in obstetrics after anesthesia is given and an OB patient is laying down. However, we only use about 1 or 2 of those. These packages are so small that it would be difficult to open them, put them in a piece of gauze, and then hold that up. I don't see the reason why anyone would do that to help to prevent nausea is coming on, to prevent them from getting sick, as he said, and throwing up in the OR. And that was the one point for me that was very concerning. I am with Dr. Feibel on this. In the operating room, the majority of the staff is focused on the patient, the surgeon. In most anesthesia rooms, there is or in the OR, we place a drape that separates us from the anesthesiologist. I don't know if that was the case in this room or not, because that's done mainly in OB, but it is very easy for the anesthesiologist to not be observed by the other people in the operating room because they are focusing on the patient. So my concerns mainly were that if someone was using, packages of 2 by 2 centimeter alcohol wipes to prevent nausea, usually you only need a couple. And in addition, I think there's just been poor judgment. If you are feeling that ill, and as a surgeon and a pregnant surgeon operating on individuals, I have felt that ill before, and I have said that I need to step out of the OR and have walked away from the table, and another surgeon has come in to continue the case. I did not leave the room and then come back. I let another provider take care of that patient because our ultimate goal is to protect the patient. And anesthesia was very helpful with that. They made sure there was a chair available. But as a surgeon, and also I would think Dr. Sowen can attest as an anesthesiologist, if you're feeling that ill, you do not take care of a patient. And our goal is to protect our patients. So in that aspect, I feel that the doctor's judgment was very poor.
Thank you, Dr. Johnson. Any further discussion? Okay, so why don't we have a vote then? A roll call, please, to approve and confirm the proposed findings, fact, conclusions, and order as presented in the matter of Dr. Hanover. We'll just sort of see where we are, okay? Dr. Rothermel.
Abstain.
Dr. Safran.
Abstain.
Mr. Giacalone.
Just to clarify, this is for conclusions, law, and scientific facts, and the order?
And the order.
Okay,
For the pending revocation.
Abstain.
Dr. Sowen.
Yes.
Dr. Johnson.
Yes.
Dr. Kakarala.
Yes.
Mr. Ganadakis.
Yes.
Ms. Montgomery.
This is odd, but you've made some good arguments. I'll vote yes.
Dr. Feibel.
Yes.
Dr. Bechtel.
Yes.
And myself, Michael Schottenstein, yes. Thank you. That matter is concluded. I will now entertain a motion to go into executive session to confer with the medical board's attorneys on matters of pending or imminent court action and for the purpose of deliberating on proposed consent agreements and the exercise of the medical board's quasi-judicial capacity and to consider the appointment, employment, dismissal, discipline, promotion, or compensation of a public employee or official. Motion, please.
So moved.
Dr. Safran and
Second.
So much. Roll call, please. Dr. Rothermel.
Yes.
Dr. Safran.
Yes.
Mr. Giacalone.
Yes.
Dr. Sowen.
Yes.
Dr. Johnson.
Yes.
Dr. Kakarala.
Yes.
Mr. Ganadakis.
Yes.
Ms. Montgomery.
Yes.
Dr. Feibel.
Yes.
Dr. Bechtel.
Yes.
And myself, Michael Schottenstein, yes. The time is now 11:32 a.m. and the board is in executive session.
Please hold just one moment while we end our live stream.